Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet is a digital partner for this particular event. And the focus of today's session is total intravenous anesthesia. And now I would like to invite Dr.R.L.Meenakshi Sundaram sir, our distinguished anesthesiologist and academic leader. Sir has served as a dean and DME at several government medical colleges, including Penny and Stanley Medical College, Chennai. He is a former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of IAC Tamil Nadu state branch. And now, sir, we can proceed with the session, sir. Over to you, sir.
Thank you very much. At the outset, I request our president, Dr. Munian, to offer his presidential address.
Good evening all. On behalf of IAC Puthukkottai City branch, I welcome the moderator, faculties and the delegates for the online webinar, which is a 31st episode of second edition of IAC Puthukkottai City branch. Today we are going to conduct total intravenous anesthesia. Total intravenous anesthesia is a technique where general anesthesia induced and maintained solely through the intravenous drugs, eliminating the use of inhalational agents. What is total intravenous anesthesia? It involves administering a combination of intravenous agents such as propofol with variable narcotics like fentanyl and remifentanil and all, with other narcotics and muscle relaxants to achieve general anesthesia. The approach allows for precise control over the depth of the anesthesia and a rapid recovery. The ideal drug for intravenous anesthesia should be rapid onset and recovery, potent and lipid soluble. No perivascular sloughing if extravasated, should not be observed with plastics. Most importantly, should be compatible with other agents when it mixed. The combination of drugs like remifentanil and propofol, and propofol with fentanyl, ketamine, propofol, and dexmedetomidine, and other various combination of drugs are available, which will be discussed by our eminent speakers. On the what are the techniques we are using? Intermittent bolus and fixed dose control, and most importantly, nowadays we are using TCI. And what are the indications for total intravenous anesthesia? Malignant hyperthermia, long QT syndrome, history of severe post-operative nausea and vomiting, surgery requiring neurophysiological monitoring, and anesthesia in non-operating theatre environment, and transfer of anesthesia patients from one place to another. What are the advantages of the total intravenous anesthesia? Like, it is more predictable onset and stability of maintenance, elimination of volatile anesthetics and other potential side effects, reduce the risk of post-operative nausea and vomiting, most importantly, cost effective. Disadvantages of the total intravenous anesthesia like pharmacokinetics and pharmacodynamic variability of response to injected agents, lack of ability and accurately assess the actual blood levels, and requires specialized equipments and trainings. Best practices: use of target controlled system to achieve precise control over the anesthetic delivery system. Monitor the patients closely for signs of awareness or inadequate anesthesia. Follow established protocols for TIVA, including dosage guidelines and emergency protocols. By following these guidelines and best practices, anesthesiologist can ensure safe and effective use of a total intravenous anesthesia for a wide range of patients and procedures. Our speakers are interested to share their experience with all of us. Let's listening the online webinar. Thank you all, sir.
Thank you, President. Now I request Dr. Kannan, our secretary, to offer his report.
Good evening all. I am Dr. Kannan, Secretary, IAC Puthukkottai City Branch. Successfully, we are conducting 31st webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is total intravenous anesthesia. Our president has elaborated very well. And last week, 30th webinar we have conducted on 13th August. Last week, our topic was pediatric anesthesia. We have divided the topic into 3 subtopics. First one is thermoregulation in children. Second subtopic is anesthetic management of hydrocephalus and meningomyelocele. Third subtopic, anesthetic management of inguinal hernia with ASD. Our moderator was Dr. Anshu Gupta, Director Professor, Lady Hardin Medical College, New Delhi. First subtopic was done by Dr. Mutiala Hasni, Senior Resident, Lady Hardin Medical College. Second subtopic was done by Dr. Sasmita Das, Assistant Professor, Lady Hardin Medical College. Third subtopic was done by Dr. Preeti Goyal Vashni, Professor, Lady Hardin Medical College. Around 875 delegates have attended the last webinar. Faculties in medical colleges kindly encourage your postgraduates to attend our webinar. We thank our academic chairman, Dr. A.L.Meenakshi sir, for continuing this academic program successfully. Thank you very much, sir. I hand over to you, sir.
Thank you, Mr. Secretary. Now it is my duty to introduce the faculty to the delegates. But at the outset, I'm happy today. See, this webinar has reached each and every corner of India, I can vouch, because I have received so many congratulatory messages. And this week is a special because I have received many messages, even indicating the topics to be covered. And they wanted to be a part of this. And even this ClinNet platform has asked us to conduct a monthly meeting separately involving all the specialties of medicine, not only anesthesiology. And I have received many messages from non-anesthesiologists also. So literally, I was happy today that we have reached so many people, this Puthukkottai city branch. And today, the peculiar thing is, see, all the speakers are from across the country, because the postgraduate is from Puducherry, and the speaker, Dr.R.Sripriya, is from Andhra Pradesh, and Dr.Tushar Chokshi is from Gujarat, and Dr. Subramanyam Mahankali is from Karnataka, and it is running by a Tamil Nadu city branch. So it is a phenomenal thing. Only occasionally we will have this sort of thing, and really we are wondering how it is happening, and all are stalwarts in their field. And at the outset, I thank everyone for accepting our invitation to educate the youngsters and the postgraduates in anesthesiology, because it is very difficult to catch them in person. So they are ready to spend their time for the benefit of youngsters, as well as they are giving a chance for us to host them. And in Tamil, there is a proverb, in a garland, the thread also smells. It has fragrance because of the flowers in it. So the Puthukkottai city branch is having a fragrance as a thread, because this thread has connected all the faculty across the country. So we thank all the flowers for making us to celebrate the fragrance. And I thank you. And Dr. Shruti, the postgraduate from Mahatma Gandhi Medical College, actually she was located by none other than Professor of Anesthesia, Mahatma Gandhi Medical College, Dr. Parsarthi. So if he picks up a person, it means the person will have great skills. So accordingly, he has picked up Dr. Shruti, and Dr. Shruti is from Chennai, and she is doing her MD post-graduation in Puducherry. The two things I want to tell about Shruti. One is she is a eligible person. She is waiting to get a pair for her. So now it will be, I'd say, it will be seen at least by 800 people. So Dr. Shruti is an eligible bachelor. I want to tell that first, because occasionally this Puthukkottai Bhudhan will act as a matrimonial service. And she is a district tennis player. So her stamina, you can assess how he is playing tennis, because she is not moving here and there. The wind will move here and there. It will make her move. So she is maintaining the stamina. She is a district tennis player. I wish her all the best. And it will be followed by additional professor, from the PG cadre to additional professor, Dr. Sripriya. Dr. Sripriya is working in All India Institute of Medical Sciences, Mangalagiri. So she is having so many degrees. Sripriya name is small, but if you add the degrees, it will run to some 26 or 28 letters. And she is a IDRA. She has a fellowship in ultrasound guided regional anesthesia. She is a MNAMS graduate also. She is interested in regional anesthesia, anesthesia machine, and safety standards in anesthesia. So I met her in Tirupati conference. So she will be always enthusiastic. She will be always brisk, and she has so many achievements because she has published 28 national publications and 23 international publications. How come she has done all these things? She is practicing only anesthesia. She knows only anesthesia, and she knows only anesthesia, and except that she is not concentrating on any other thing. So she has won the best peer reviewer award from the IJA. She got the best publication award from GARG 2024 and the international best researcher award from ISSN, and she's associated editor of JOACP. So such a great stalwart. She has authored chapters in anesthesia machine and its components and anesthesia breathing systems. And she has a copyright of a video demonstration of low flow anesthesia. See, you can see her lectures will be of high flow, but she is having a video on low flow. So it is quite nice, and we are fortunate to have her here. It will be followed by the infographics man, the intelligent graphics. I don't call it as infographics. Even people who have not seen Dr. Tushar Chokshi, if you say infographics, immediately they will know. Yes, yes, yes. One person will be posting all infographics. He is called as an infographics man. But Dr. Tushar is a paper crafting teacher. He has so many extracurricular activities which I want to focus. He is a consultant. He is a private consultant in Vadodara, but he has devoted his life for academics. So he is naturally intelligent to educate us about artificial intelligence. That is the beauty of Dr. Tushar. Tushar is having 33 years of anesthesia expertise. So he is mainly concentrating on uro anesthesia, laparoscopic anesthesia, ENT pediatric. In addition, he is concentrating on chronic pain relief. So that is very great part of him. And he has delivered 300 webinar lectures. Same way, 300 conference lectures also. And he has popularized TIVA, that is Total Intra Venous Anesthesia, by his WhatsApp group. He is always exchanging knowledge and enriching material, and he is a visiting faculty at Parul and Savita Medical Colleges in Eurocare Hospital, all in Vadodara, Gujarat, and he is a founder of AOTTA. That is a great part of it, and he has Facebook groups for all his commitments. He devotes minimum 2 hours for this social media, and all are educational only. That should be appreciated. And even he has delivered a lecture how these infographics you can create, and with the infographics how you can earn. So he is asking us to learn as well as earn by these infographics. Anyway, in Tamil there is a proverb: after seeing a tiger, this cat with a red hot iron rod, he has drawn the lines. It will be like that. We cannot follow the speed of Tushar in the infographics, and he has started a smartphone and a tele anesthesia. So even he can anesthetize me. Already he has anesthetized me sitting in Gujarat because of his smartness. Through his smartphone, he is doing the thing, and for the he is propagating the knowledge in artificial intelligence, infographics, chat GPT, and even he says the slides could be prepared within 5 minutes. But I don't know how he is doing it. It is very difficult for us. Even though there are so many advances in that, we are preparing the same way. We are spending some 7 to 10 days to prepare the slides. So, Dr. Tushar, we are very happy to have you here. And when these stalwarts are there, then I was wondering how to fix the moderator. Then immediately the name of Dr. Subramanyam Mahankali came to my mind. See, he is such a wonderful personality. Immediately he has accepted. He has not even asked me. I just dropped a message because he is so busy to be contacted over phone. Immediately, that sort of a humbleness our moderator has. But don't think that he is just because he has accepted Puthukkottai Bhudhan, he is not an average skilled man. See, he is alumni of the prestigious institute, All India Institute of Medical Sciences, New Delhi. He has done his MD there. And the poet Bharati in Tamil used to say, if it is a real skill, even the foreigners will salute it. So they have saluted Dr. Subramanyam Mahankali. He has gone to UK. He was appreciated there like anything. And he got the Royal College degree also. So he is a FRCA. Very few people are having that FRCA degree in India. And he is one among them. I think it will be less than 5 only. So he is such a great scholar with a lot of publications. He has worked in UK, then he moved to Karnataka, and he is a founder member of this AOTTA. And I want to say he is the president of the association. So now we are very happy for this TIVA. We have the president. Already we have the president of pediatric anesthesia. We have the president of obstetric anesthesia. Now he is a president of AOTTA, and he is a past section editor in clinical pharmacology. That is also an added point for our moderator, because all pharmacology of the drugs they are going to talk. And he is an editorial board member of Indian Journal of Clinical Anesthesia. And he digital health newsletter also. He is a editorial board member, and he has special interest in editorial digital health, and he is very good at digitalization of anesthesia. He is popular at Nottingham University also. So thoroughly he has enjoyed his stay in UK, and he has come to India to educate us all the specialities of anesthesia. And he is one of the first certified digital health professionals in India. That's what I want to say. He's the first one, and he has delivered more than 50 invited talks on regional anesthesia and TIVA. And we have him here. He has organized around 15 workshops in TIVA. So I have fixed up the correct person to be the moderator for this, so that Dr. Sripriya and Dr. Tushar will also vouch that they are having a good moderator. And he has been nominated member of the National Academy of Medical Sciences. He is already a MNMS graduate, and he is now a member of the board, and he has contributed 2 chapters in Yearbook of Anesthesiology. So even he is moved. Every successful man will have one woman behind their back. But now, behind the back of Dr. Subramanyam Mahankali, we can see how much of books he has. And all the books are in the shelf, but the contents are in his mind. So over to you, Dr. Subramanyam, sir. Please take it forward.
Sir, nobody can beat you in how to introduce people. Thank you. We are all small fishes, and the way you introduce, you make us feel really special. Thank you, sir. Now, what I am really glad is today, the entire spectrum, what is involved, what is required, is being dealt with. This TIVA is not something new. It has not come today. People used to practice total intravenous anesthesia nearly 2.5 decades as well. But the understanding behind it and the development of target controlled infusion and all the models behind it has been tremendous. As far as I can see, this the educational material seminars which Dr. Meenakshi has started, it's taking to every part of India. TIVA, TCI will go each and nook and every corner of the country, because you don't need 70 lakh anesthesia machine. This can take you anywhere and give you a safe anesthesia anywhere. So understand the basics. We have for the PGs, Dr. Shruti is talking about the basic pharmacology of propofol and fentanyl, which form the basis for TCI TIVA. At least now there are newer drugs in the pipeline, and the pharmacology of this, how it does, is something entirely different arena, because in anesthesia we have a very different way of looking at things. We want drugs to work quickly. At the end of the surgery, we need to switch off to come out very quickly. And Dr. Sripriya is going to add us why we should know pharmacokinetics and pharmacodynamics, and which makes this unique compared to any other specialty. And to top it all, Dr. Tushar will deal about smart anesthesia, TCI pumps, how to use it and how to use it smartly as well. So I can't wait for it, and I'm happy to. We'll take the questions at the end. We will note down the questions. And Shruti, this stage is all yours. All the PGs, listen to this talk very carefully. you have a lot of learning material there. If you're a practitioner, the Tushar and Dr. Sripriya are there to make you excited and take and practice every day. Thank you, sir.
Good evening, one and all. I'm Dr. Shruti, postgraduate from Mahatma Gandhi Medical College and Research Institute, Puducherry. I'll be presenting on the pharmacology of propofol and fentanyl. Propofol is a non-barbiturate IV induction agent used for maintenance and also for procedural sedation. It is chemically 2,6-diisopropyl phenol, which is a 1% milky white solution, which is lipid-based and containing soybean oil, egg lecithin, and glycerol. It is commonly called as milk of amnesia. So it is available commonly as 1% solution, rarely as a 2% solution, and for pediatric use, it is 0.5% solution. Its pKa is 11 and it is also available as preloaded disposable syringes. Uses and dosage. As an induction agent, it is used as 1 to 2 mg per kg. For maintenance, it is 50 to 200 mics per kg per minute. And for sedation, it is 25 to 100 mics per kg per minute. No other available routes of administration. Adequate depth of anesthesia can be assessed by loss of verbal contact, which is a better predictor than loss of eyelash reflex. Its difference from other IV induction agent is that it has a more clear-headed recovery, less antanalgesia, that is, on co-administration with other opioid analgesic, it does not reduce the efficacy. There is MAP reduction and decreased cerebral perfusion pressure. Post-operative nausea and vomiting is less due to its action on D2 receptors. Supraglottic airway device is better tolerated due to its blunting of airway reflexes. Amnesia is better. It is used in bronchospasm and also in malignant hyperthermia and porphyria. Its disadvantages are its pain on injection and myoclonic jerks and subcortical inhibitory glycine antagonism. Green urine following a single induction dose of propofol is a study conducted by Dr. Sripriya ma'am, and it is one other side effect. Propofol infusion syndrome is a rare but serious side effect of prolonged infusion of propofol, usually more than 4 mg per kg per hour for more than 24 hours, and it presents as metabolic acidosis, hyperkalemia, hyperlipidemia, rhabdomyolysis, and may proceed to renal and cardiac failure and ultimately death. In special population, it is used in children less than 2 years of age. In pregnancy, previously it was considered unsafe due to its due to hypotension, and emerging evidence suggests potential safety, though caution remains advisable. Moving on to fentanyl. Fentanyl is a synthetic opioid agonist acting on new receptor. It is a phenylpiperidine derivative, structurally similar to pethidine. It is about 75 to 125 times more potent than morphine. Context-sensitive T-half of fentanyl group. Context-sensitive T-half is defined as the time taken for plasma concentration of a drug to fall by 50% after stopping an infusion, considering the duration of an infusion. With fentanyl, the slope shows a steep rise. After a short infusion, the elimination is rapid. After prolonged infusion, drug accumulates in tissues, so the clearance is delayed. Even when infusion is stopped, respiratory depression and sedation can persist. This is in contrast to other newly available opioids like alfentanil, sufentanil, and remifentanil. Remifentanil maintains a nearly constant context-sensitive T-half of about 3 to 5 minutes, and it's hence preferred in TCI. Uses and dosage. It is used in intra-op analgesia with a dose of 1 to 2 mics per kg, 2 to 10 mics for blunting intubation response. It is used in patient-controlled analgesia, patient-controlled epidural analgesia, in intrathecal and epidural infusions, transdermal therapeutic system, oral transmucosal fentanyl citrate. Target-controlled infusion. Computer-controlled infusion pump calculates infusion rate from target concentration and delivers the required volume. Moderate to strong analgesia is achieved with 1.5 to 5 nanogram per ml. 50% MAC reduction is with 0.5 to 2 nanograms per ml. Surgical anesthesia with 50% nitrous is with 15 to 25 nanograms per ml. Oral transmucosal fentanyl citrate is a solid formulation of fentanyl that resembles a lozenge on handle. There is rapid onset of analgesia. Fentanyl begins to cross blood-brain barrier in as less as 3 to 5 minutes, and its peak effect is achieved at 20 to 40 minutes. Total duration of activity is 2 to 3 hours. It is also available as 200 to 1600 mic dosage strengths and is used in breakthrough pain in cancer. Transdermal therapeutic system. It is a fentanyl patch available in 4 sizes and causes sustained release of fentanyl at rates of approximately 25 to 100 mics per hour for periods of 48 to 72 hours. The patch is attached to a skin by a contact adhesive, adjacent to which is a microporous membrane that controls the rate at which fentanyl is transferred from the drug reservoir to the skin. So to summarize, propofol is a versatile and reliable IV anesthetic with rapid onset and smooth recovery, though vigilance is essential to avoid its adverse effects and infusion-related complications. Fentanyl is commonly used opioid analgesic that is highly potent, excellent analgesia, and versatile administration routes are available, though there are risks of respiratory depression, dependence, and tolerance. Thank you all for the opportunity.
Thank you, Shruti. That was a very lucid and brief introduction into the key drugs which are involved in total intravenous anesthesia. Thank you, Ma. Thank you very much. Probably we'll take the questions at the end. We will let Dr. Sripriya take this stage. But what I can honestly say for everyone is propofol is like the mother of all drugs for target controlled infusion. A lot of developments have happened because we have learned a lot from propofol, how to use it. That led to a group of drugs, what we call as soft drugs, the typical of which is remifentanil as well. So the remifentanil is a kind of drug which all the AI and the newer drugs discovered will be probably based on something like remifentanil. So especially the metabolism and the organ-independent metabolism and quick offshoot are the key things when we are performing target controlled infusion or TIVA. So now to understand why TCI, what kind of induction, what it makes a difference, why it works quickly, why people know how to estimate that how much dosage is required, and how quickly they wake up. All this we can learn by understanding pharmacokinetics and pharmacodynamics. Carefully, you slipped in a few important things there. See, generally, when we talk about drugs, we've always talked about dosage. Dosage means milligram per kg. For the first time in anesthesia, of all the fields, we are talking about concentration in the blood, concentration in the brain. That is what TCI is for. So you are deciding how much to give, estimate the concentration in the blood and in the brain. That is the fundamental of TCI. Now, no better person than Dr. Sripriya, who is such an academic credential. Anyone would love to have. We want to hear from you, Dr. Sripriya. What are the underlying pharmacokinetics, pharmacodynamics, which all of us should know. And before we touch our machine hands and those pumps and the glittery buttons, before we start using it. Thank you. Stage is yours.
Very good evening, one and all. At the outset, I thank Dr. Meenakshi Sundaram sir and Puthukkottai Bhudhan team for providing me this opportunity to be presenting today. So the topic I'll be talking about is pharmacokinetic principles of intravenous drugs. I bring greetings from my institute, AIMS Mangalgiri. And this is a brief outline of my talk. We'll first understand the pharmacokinetics of intravenous drugs using the 3-compartment pharmacokinetic model. A few terminologies in pharmacokinetics, such as volume of distribution at steady state, what is front-end kinetics, what do we mean by plasma concentration, what do we mean by effect site concentration, what do we mean by clearance, and what is meant by elimination. What are the principles behind the BET regimen for total intravenous anesthesia? And finally, the back-end kinetics and context-sensitive half-life. So in my presentation, I have used propofol as an example for understanding the pharmacokinetic principles. And I've also used the TIVA plus Android app for creating a few pharmacokinetic graphs. So what do we mean by pharmacokinetics? Pharmacokinetics tells us the relationship of drug dose to the plasma concentration or the effect site concentration over time. As anesthetists, we use multiple drugs and all these drugs are given intravenously. So these principles form the background for understanding how to administer intravenous drugs to the best advantage. And pharmacokinetics also forms the basis for total intravenous anesthesia and target control infusion. The simplest way of understanding the relationship between dose and concentration is the water tank model. Consider we have added 1000 milligram of a drug to a tank containing 1 liter of water. The concentration of drug in the water can be determined by dose divided by volume in which the drug gets diluted. So in this example, it is 1000 milligram divided by 1 liter of water that gives a concentration of 1 milligram per ml. So in pharmacokinetics, the volume in which the drug gets diluted in the body is called volume of distribution. Now, suppose we do not know the volume of the tank. Then again, by measuring the concentration that we can attain in the water and by rearranging this equation, we can determine the volume of distribution. And in this instance, it is 1000 milligram divided 1000 milligram added to, we don't know the volume of the tank, but the measured concentration is 1 milligram per ml. So it is 1000 divided by 1, we get 1000 ml. In the human body too, the volume of distribution is difficult to measure, but the plasma concentration can be measured by drawing arterial samples at various levels, and the volume of distribution can be calculated. Now, what is the plasma concentration of propofol following a single induction dose? Most commonly used dose is 2 milligram per kg. So unlike the water tank model, the plasma concentration is seen to rapidly change with time. The max concentration is attained soon after injection, following which there's an exponential decline which occurs in 3 phases. The first phase, there's an initial rapid decline, then followed by this, there's a slow decrease. And a third stage, we have a steady but stable decrease. And what are the pharmacokinetic processes that are involved in causing this sort of an exponential decrease in the concentration? So pharmacokinetics primarily involves 4 processes. One is absorption, distribution, elimination, which takes into consideration both metabolism and excretion. Now, as anesthetists, all the drugs we use are given intravenous. It is the rapid rise in plasma concentration that is very necessary for the anesthetic action. Therefore, absorption does not play a role. So the pattern of decline that we see is primarily decided by 2 factors. One is distribution and the other is the elimination. And exponential decline that we see following injection of propofol can be understood from the 3-compartment pharmacokinetic model. The first compartment in this model is compartment T1. It is also called the central compartment. It includes tissues such as blood and lungs. The effect site for all anesthetic drugs is brain. The effect site is also considered a part of the central compartment only. So intravenous drugs, we are directly injecting it into the central compartment. The concentration that is attained depends on the volume of the blood as well as volume of the central compartment. So now a fraction of the drug gets attached to the proteins, a fraction remains in free form, and this free form is now available to get redistributed to all the other body tissues. The second compartment in the three-compartment model, that is the compartment B2, comprises of organs such as liver and muscle. This compartment receives a very high blood flow and it is of limited capacity. Therefore, it equilibrates very rapidly and therefore it is called the rapidly equilibrating peripheral compartment. The third compartment in this model is the compartment B3. This is called the slowly equilibrating peripheral compartment, comprises of tissues such as fat and skin. So this compartment receives less blood flow and the capacity of this compartment is immense. Now, if you look at the size of these chambers, the size of compartment B3 is very huge. This not only takes into consideration the proportion of body weight, but also takes into consideration the tissue solubility of drugs. And most of our anesthetic drugs, as I mentioned previously, are lipid soluble. So the effective volume of this compartment is very huge when compared to either the central compartment or the rapidly equilibrating compartment. So this is called the slowly equilibrating peripheral compartment. Now the size of the pipes here represent the percentage of cardiac output or the blood flow that is happening to each one of these compartments. And the kinetics that govern intercompartmental transfer is given by the rate constant K. So the kinetics that govern the transfer between compartment V1 to V2 is given by the constant K12. And between V1 and V3 is given by the rate constant K13. Apart from this, a certain proportion of the drug will also get metabolized and excreted. The kinetics that govern this is K10. As the plasma concentration begins to fall because of elimination, there's again a distribution of the drug from V2 and V3. The drug re-enters the compartment V1. And the kinetics here is K21 and K31. So, if you again come back to this graph, the maximum concentration is attained soon after injection, following which the first phase, and that is a steep decline. This occurs because of the movement of drug from the central compartment into the rapidly distributing compartment, rapidly equilibrating compartment. In the second phase, what has happened? The rapidly equilibrating compartment has already equilibrated, but there's a slow continuous movement of drug that happens from V1 to V3. And as the concentration in V1 decreases, the drug again moves back from V2 into V1. So the decline that is happening here is slow. The third phase is the elimination phase. Here, metabolism and excretion has taken over, and the concentration in V1 begins to decrease. Therefore, the drug movement now begins to happen from both V2 into V1 and V3 into V1. So therefore, the drug concentration in the plasma lingers at lower level for a longer duration. So primarily, basically what is happening is that plasma concentration continuously decreases over time. The rate of decline is initially rapid, but becomes less steep until we get to a portion that is log linear. Now the plasma concentration, we saw that it is inversely proportional to the volume of distribution. Soon after injection, we get the maximum concentration. That means the volume of distribution here is relatively less. But if you look at 4 minutes, the concentration has come down. That means the volume of distribution of the drug has increased. But it is not only this. Elimination also causes a decrease in the concentration. So what we have to remember is, for the first 4 minutes after administration of propofol, the effect of redistribution on plasma concentration is greater than that of elimination. Following 4 minutes, it reverses. Now, the next terminology we have to understand is volume of distribution at steady state. VDSS is the sum of all volumes of distribution when all compartments are in equilibrium. That means, so here, this is a screenshot I've taken from the Euro Society of Intravenous Anesthesia based on the Marsh model. So here we can see that in all the compartments, the concentration of propofol is 6.1, which means that there's going to be no more intercompartmental shifts that happen. The decrease in concentration from plasma will only happen because of elimination. So this takes actually, for VDSS to reach, it takes a very long time. For propofol, it takes as long as 25 hours of propofol infusion. And the VDSS of propofol is like 300 liters. For thiopentone, the VDSS is around 190 liters. And when we look at the opioids, for remifentanil, the VDSS is 21, alfentanil 37 liters. Fentanyl, it is somewhat similar to propofol, it is 300 liters. So again, another thing we should know is the therapeutic range or the dynamic range. It is the range of drug concentration that is required for an effect. So for propofol, it is between 1.5 to 5 microgram per ml. Below this therapeutic range, we do not see any effect. And above the therapeutic range, there's no additional effect that we get. Again, the target concentration depends on the desired depth of anesthesia. For surgical anesthesia, we may need somewhere between 3.5 to 4 microgram per ml. But if it is only for sedation, 1.5 microgram per ml will be adequate. For laryngeal mask, it is between 2 to 3 microgram per ml. But for intubation, we need a higher concentration, somewhere between 4 to 5 microgram per ml. So the effect site concentration primarily depends on the target goals. Conventionally, just as Dr. Subramanyam Mahankali sir was saying, conventionally, we have been remembering drug doses in terms of milligram per kg. Such as for propofol, it is 2 milligram per kg of propofol for induction. Or for TIVA also, we used to think it is like 10 milligram per kg per hour of infusion. A paradigm shift when we started using TCI system is we should know what is the effect site or a plasma concentration we need to set to achieve anesthesia. So this is the TCI pump. What we have set here is a target concentration or the effect site concentration of 4 microgram per ml. Likewise, this is the ITIVA simulation app. Once you start using it, you'll know that it will ask us what is the effect site concentration you want to start with and what is it you need it for maintenance. So although we consider the effect site as a component of the central compartment, still the effect site concentration slightly lags behind the plasma concentration during induction. So this is because the drug has to move along the concentration gradient. For a probability of anesthesia in 50% of patients, if the plasma concentration is around 5.6 microgram per ml, the effect site concentration at that point of time is only 4.5 microgram per ml. So this is one thing we have to understand, the difference between plasma concentration and the effect site concentration, that is C. Biophase refers to the time delay between changes in plasma concentration and the drug effect. Now this is a graph. I have made it with ITIVA app. The line in red shows the plasma concentration and the blue line is the effect site concentration. So soon after intravenous induction dose, the plasma concentration has soared up. CP has increased to 23.4 microgram per ml. But at that point, the effect site concentration is only 0. In the next minute, the effect site concentration has reached around 5.49 microgram per ml. Over the next 3 minutes, it remains above 4 and falls to below 1.5 in another 3 minutes. In the decrement phase, again, we can see that the effect site concentration is greater than the plasma concentration. And now the movement of drug happens from the brain into the plasma. What is clearance? Clearance is volume of plasma that is cleared of a drug. There are two processes that contribute to clearance. One is what we saw is the intercompartmental clearance. That is distribution, because of distribution of drug from the central compartment into the peripheral compartments, there's a decrease in plasma concentration. This is called intercompartmental clearance. The second one is the systemic clearance, and this is responsible for eliminating the drug altogether from the body. The unit for clearance is liters per minute. Now, elimination can involve one of the two processes. One is first order kinetics or the zero order kinetics. In first order kinetics, a fixed fraction is eliminated per unit time. So in the example I've taken here, in this graph, you can see that if we have begun with a drug concentration of 100 microgram per ml in the plasma, over the first 1 minute, there's a decrease in 50% concentration of the drug. So it comes to 50 microgram per ml. In the next minute, again, there's a 50% decrease, but this time the milligram that is eliminated is only 25. The third minute, it is 12.5. Although the concentration is decreasing at 50% per minute, the amount of drug that is eliminated per unit time varies. In zero order kinetics, it's a fixed amount of drug that is eliminated per unit time. In this example, if we say from 100, if 10 microgram per ml, 10 mics is getting eliminated, it decreases to 90, 80 after every minute. So it is linear, but here the decline is exponential. Majority of the anesthetic drugs follow the first order kinetics for elimination. So over 5 plasma half-life, after 5 plasma half-life, the drug concentration had decreased to a level which is less than the therapeutic level. The unit of clearance is liter per minute, but the elimination rate is described as milligram per minute. So earlier we saw the volume of distribution of propofol and thiopentone, which was 300 and 190 liters. Now if you look at clearance, the clearance of propofol is 1900 ml per minute, while for thiopentone it is only 215 ml per minute. So this can tell us that although thiopentone had a smaller volume of distribution, why is propofol more suited for total intravenous anesthesia or TCI? This is because of the clearance. For remifentanil, the clearance is 2600 ml per minute. Alfentanil is 300. Fentanyl is 1000 ml per minute. So here we have to observe the volume of distribution of remifentanil is only 21 liters and the clearance is 2600 ml per minute. That means this we can easily titrate the levels of remifentanil in the blood. So this is why it is best suited for total intravenous anesthesia. So following a single intravenous induction dose, the plasma concentration of propofol remains in the therapeutic range for around 8 minutes. But if we see the level of surgical anesthesia, if you want it above 3 microgram per ml, it remains there only for around 3 to 4 minutes. So for TIVA, if you have to maintain plasma concentration in the therapeutic range, it means it is well, we can interpret that we will need to administer propofol as an infusion. Now consider I've started an infusion of propofol at 60 ml per hour. So initially there's a rapid increase in plasma concentration, but slowly what happens immediately there is the rate of increase in plasma concentration plateaus. And even after around 25 minutes, we have not been able to reach around 3.5 or 4 microgram per ml. That is, if anesthesia is induced by infusion alone, it takes much more time to attain the desired concentration. So one may question saying that probably the infusion dose of 60 ml per hour was not adequate. Why not increase to 120 ml per hour? So what happens? Now I have increased the infusion rate to 120 ml per hour. Yes, we could attain the plasma concentration of 4 very rapidly within 3 minutes itself. But what we see is by around 10 minutes, the plasma concentration and even the effect site concentration overshoots the required target. This is again not favorable as a stable target concentration cannot be maintained. So for total intravenous anesthesia, we want the therapeutic levels in plasma to be attained fast, but it should be maintained also. So the BET regimen for propofol was designed to meet these requirements, B standing for bolus, E for elimination, and T for transfer. So the loading dose takes into consideration the volume of distribution of the central compartment as well as the plasma concentration we want. The primary intention is to fill the central compartment, and this has been determined to be around 1.5 milligram per kg of propofol. This should be followed by a constant rate infusion, which should take into consideration the decreasing plasma concentration that is happening because of intercompartmental transfer as well as elimination. And we have seen earlier that both of these decrease exponentially. Therefore, in the BET regimen, the infusion dose was somewhat like this. Starting after following the bolus, we are going to start with an infusion dose of 10 milligram per kg per hour for 10 minutes, followed by 8 milligram per kg per hour for 10 minutes. And this is followed by 6 milligram per kg per hour for the remaining duration. And how does the plasma concentration remain if you are using this infusion regimen? So here we can see that the plasma concentration and the effect site concentration has attained very fast, and it remains at the therapeutic range of 3 microgram per ml. So decrement following a single bolus dose of propofol occurred in around 8 minutes if the target what we have set is 1.5 microgram per ml. What happens to the decrement time following infusion? This is what is called the back-end kinetics. Now consider that we have run infusion of propofol to maintain effect site concentration of 4 microgram per ml. And if this infusion has been running for around 30 minutes, how much is the time it takes for the plasma concentration to decrease to 0.5 microgram per ml? This has been determined to be around 30 minutes. While if the infusion has been running for 40 minutes, for 60 minutes, it takes 40 minutes for the plasma concentration to decrease to 0.5 microgram per ml. And now if the infusion has been running for 120 minutes, it takes 65 minutes for the plasma concentration to decrease to 0.5 microgram per ml. So the decrement time has been seen to increase with the increase in duration of infusion. This is because following a single dose, the recovery occurs primarily due to redistribution. But following infusion, there's accumulation of blood in the tissues and elimination becomes important. Context-sensitive half-time is another important terminology. It is the time taken for a drug's plasma concentration to decrease to 50% after discontinuation of a continuous intravenous infusion that maintained a steady plasma concentration. The context here being the duration of infusion. For hypnotic drugs, if you see the context-sensitive half-life, the one in purple is propofol. The context-sensitive half-life of propofol does not vary with the duration of infusion. On the other hand, if we see thiopentone, it increases. The context-sensitive half-life increases with the increase in duration of infusion. For dexmedetomidine, is the line in green, up to 100 minutes, there's an increase in context-sensitive half-life, after which it plateaus. That means if you have stopped a dexmed infusion that has been running for 200 minutes, the 50% decrement is around 70 minutes, but it is the same 70 minutes even if you have run the infusion for around 400 minutes. So now propofol is most suited because what we see is irrespective of the duration of infusion, the context-sensitive half-time is predictable. In case of opioids, remifentanil has a very good pharmacokinetic model because the context-sensitive half-life is 4 to 5 minutes irrespective of the duration of infusion. For fentanyl, up to 120 minutes, you see that it is around 50 minutes, but after 120 minutes, there's a rapid increase in the context-sensitive half-life. So we should keep this in mind while using fentanyl for total intravenous anesthesia. So we should appropriately time when to stop the infusion if you're planning to extubate a patient. The TCI pumps also provide us an option to know the time it will take to decrease to a particular target concentration. So here, I have entered is I want to know how much time it will take for the plasma concentration to come down to 1.5 microgram per ml, and it tells me that it is around 8 minutes. Likewise, even our ITIVA app is giving us a mechanism to know the decrement time. We have to enter the duration of time the infusion has been running. Here I've entered it as 20, and it tells me that the effect site concentration will decrease to 1.5 microgram per ml in the next 5.6 minutes. So to summarize, we have seen that following a single induction dose of propofol, there's an exponential decline in plasma concentration that occurs in 3 phases. The there's an initial rapid decline followed by a slow and steady decrease followed by a stable decrease. In the third phase, this can be explained by the 3-compartment pharmacokinetic model. The drug is injected into the central compartment. From the central compartment, it goes into the rapidly equilibrating compartment very fast, but this compartment also equilibrates rapidly. This causes a rapid initial decline, following which the slow movement of drug into the compartment V3 causes a slow decrease. The third phase is the elimination phase. That is when elimination of a drug is causing a decrease in plasma concentration. Although effect site is considered a part of the central compartment, during the increment phase, the effect site concentration lags behind the plasma concentration, and during the decrement phase, the plasma concentration lags behind the effect site concentration. The bed regimen for total intravenous anesthesia is designed to deliver a loading dose followed by infusion so that we can maintain stable effect site concentration. And context-sensitive half-life is the time that is taken for the plasma concentration to decrease to 50%. Drugs which have a very fixed or a small context-sensitive half-time are the ones that are very suitable for total intravenous anesthesia. With this, I end my presentation. Over to you, sir.
Dr. Shripriya, it was, pharmacokinetics and pharmacodynamics is not an easy topic. I can see a lot of originality in the way you have presented things. Wonderful talk. A quick recap before we pass it on to the master. Quick recap, what I can generally recollect or tell about this for everyone is, the first important thing is, whenever we want to practice precision model, precision anesthesia, we need to know the mechanism of action, right? So, for example, it's a muscle relaxant. It's a specific mechanism of action. Opioid is a specific mechanism. We know where their receptors are located, where they're working. Now, when we have started using propofol, there's a clear clarity what is the mechanism of action. It works on GABA A receptors and hyperpolarizes. That's a fundamental thing which makes a shift towards TCI. The next you highlighted quite lucidly. Sir, we are not talking about dose now. We are talking about concentration in the plasma, concentration in the target site or effect site. Now, again, there's a clarity. What is that effect site? We have a clarity which parts of the brain where propofol is working. We have zeroed in with functional analysis as well as the receptor analysis. What is the target site? When you know target site, it's very easy to understand. When you know the mechanism of action, now we can start to look at how to develop that concentration. That is what has happened over the last 20-25 years. You also lucidly elucidated two important things there. What is the front-end kinetics? What is the back-end kinetics? Why it is important for us is, front-end kinetics means if we give a drug, how quickly it is going to work. You've briefly highlighted remifentanil, how quickly it works, fentanyl, propofol, etc. Again, after giving anesthesia, at the back-end kinetics, if you stop giving the drug, when will the patient wake up? Now, here gives us the clarity. We have an understanding what is the level required to anesthetize, what is the level required to start, how quickly it will work, and how the body throws out and how quickly the patient wakes up. Now, these are the fundamental essentials of modern precision anesthesia, where we can personalize it with adding patient factors. What are those individual patient factors? Age, height, gender, and weight. When we have all these things and understanding of all these things, it is going to create us a huge ecosystem wherein which the target controlled infusion will become a routine, will become precise and personalized. We can personalize it for a particular person. What a wonderful development. We also highlighted about bed regimen. Bed regimen is something which is incorporated in every model with every TCI machine. So for PGs, if you have an MCQ, bed regimen is not about betting in the IPL. It is about the bed regimen for target control infusion. You also introduced us a couple of new things there. One is you showed us the TCI pump. Wonderful, excellent. You also gently introduced, if you don't have TCI pump, there is a TIVA Plus app, iTIVA app, which you can use it to practice passive TIVA. That means use a normal infusion pump and use this TCI app to give precision anesthesia. What a wonderful introduction you have had. We can't have a better preparation for the master to come and give his master stroke and take us to the next level. Dr. Tushar, welcome. We want to hear from you. I know you will take us from normal routine to excited state. Look forward to hear from you.
Thank you, Dr. Subra. On the outset, good evening to all my webinar attendees, including my resident, my esteemed future president of ISA, my good friend, my IOTA president, Dr. Subramanyam Mahankali. And today I am very much thankful to my very good friend, academic friend, Dr. Meenakshi Sundaram, for giving me opportunity, such a august gathering in a webinar. So today's my topic is just generally offbeat topic because I am an AI man. So I will talk about the future of the anesthesia, what the smart anesthesia will look. So my topic name is Smart Anesthesia, TCI TIVA with AI integrations. There are some of the lectures on AI is very popular in all over India. So I have highlighted two quotes for there, where precision meets the intelligence in anesthesia and infusing our intelligence into the smart anesthesia powered by artificial intelligence. So first of all, I will define some of the definitions. People know the definition, but I want to highlight again, what is smart? Why we use smart everywhere? Because smart is a system, device or processes that are intelligent, adaptive and efficient, often using technology, automation and data-driven insight to optimize performance. Nowadays, you are using smartphone, smart home, smart car, smart monitoring. So specific, measurable, attainable and relevant and time-based makes goal your specific, define measurable assets, confirm your goals are attainable, verify your goals are relevant and set up time based on your plan. Suppose I don't have any idea about how to use ultrasonography machines to block my nerves. Not to worry, my AI will take over that. I will put my probe on the sonography machines of my patient's body and the AI machines will tell that this is the nerve here is lying and you just block it. So that is the way our smart anesthesia is coming in the picture. I am in this field since last 10 years and all the parts of the world where I am taking lecture, my artificial intelligence is going too much in deep. So what is smart anesthesia? The use of modern technology means TCI machines, then all our depth anesthesia monitor and AI to make both gas anesthesia as well as TIVA more precise, safe and personalized while keeping the anesthesiologist in a full control. The basic definition of TIVA, people are having a myths about this TIVA. That's why I go to some basic definition of TIVA. Dr.R.Sripriya and other PG students have explained very nicely about TIVA. But again, I want to tell total intravenous anesthesia is a technique of general anesthesia which uses combination of the drug given exclusively by the intravenous route without the use of inhalation agent, even gas anesthesia including nitrous oxide. But here oxygen and compressed air or helium are exception. So TIVA is used in induction and maintenance of anesthesia. I am also highlighting that part, whether you intubate or not, whether you give supraglottic airway insertion or not, TIVA is used in all the way. So what is TCI? Dr.R.Sripriya, my previous speaker, has explained very nicely that target control infusion is a simple definition. TCI is an infusion controlled to achieve preset drug concentration in the plasma or the effect side. You do not have to worry about the doses and pharmacology and this and that and that. Now your target control infusion pump will take over. The basic difference between the simple infusion pump and target control infusion pump is that there is a computer in the target control infusion TCI pump. This will take over then she has explained very nicely how it works. So come to the what is smart anesthesia, TCI TIVA, a closed loop or clinician guided system that combines TCI, that is target control infusion algorithm. All the algorithm she has explained very well. TIVA drugs, all the regimens and AI driven feedback. We are using all the depth anesthesia monitor, all the opioid like annual monitors, BIS monitor or hemodynamic variables to individualize the drug delivery in real time with the right patient in a right way by the anesthesiologist. That is why my downline punchline is that today's anesthesia is not going to kill any patients in future. If you want to kill your patient under anesthesia, even a particular dose, then also patient is not going to die. That is the way anesthesia is coming in the way. Now, since last 180 years, when our anesthesia introduced, we have invented 70 drugs in anesthesia and that we were using it. Out of this, these 20 drugs are not in use. This is just for our resident to highlight how these drugs are used. In TIVA, we are using 50 drugs. That is why I am the main person to using since last 25 TIVA and TCI in my practice or private practice since last 33 years I am practicing. And in TCI, we are having 7 drugs of advantages to use that part. You know that in 1990 when the sevoflurane was introduced in the market, after that there is no inhalation agent. But every year, you see, every year TIVA drugs are invented. Nowadays, next generation AI drugs are like ciprofol, which was invented last year. And coming way, Remimazolam was invented in Japan by 2 years before. They are also in pipeline. And another pump like TCI pump are in the market, will be in the market within 5 years to have these drugs on this TCI pump. Now people are telling two things. They tell that without gas anesthesia, our anesthesia is not complete. I bet that TCI TIVA completes the anesthesia cycle because it gives hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility and neuromuscular blockade. All the drugs facility, we have ample choice of using these drugs in our armamentarium, whether we are using muscle relaxant or this. This is called TCI TIVA completes. So TCI TIVA is not a bogus anesthesia. It is not a incomplete anesthesia. It gives complete anesthesia circle. There are some advantages, except for this is just for the highlight of the advantages. Except for the slight prick in the arm, the patient is unaware of the having an anesthetist. Because in gas anesthesia, we have to put the mask, we have to put on that, this and that. People may not like it. No mask over the face, no sudden concentration of gas or vapor, no risk of malignant hyperthermia. If you read your WhatsApp group, in last six months, there are 5 cases occurred in all over India because of the malignant hyperthermia, and in every city branches are keeping their dentrolene in their armamentarium. Even in Vadodara, we have kept our this malignant hyperthermia, and out of 5 patients, 3 patients died. So because of that, we are not recommended to use. No doubt, I am not against any gas anesthesia, but nowadays the coming era is of the TCI TIVA. So the no risk of malignant hyperthermia, very low incidence of post-operative delirium, less chances of emergence phenomena, better preservation of the cerebral autoregulations. It gives less PONV. In my practice, since last so many years, I am practicing as a TIVA, then TCI, then advanced TCI. I have never seen any patient having a PO, post-operative nausea vomiting, because there are so many drugs are available like Dexona, then ondansetron, then Sultaren, everything. Less operating room solution. There is no need of scavenging system. So now come to the why we need for the smart anesthesia. Here, people have to understand that suppose today I done one case, I will go practically. I have done one tonsillectomy of one 10-year-old child. The same type of the patient with the same age, same criteria that comes in the second day for the tonsillectomy. But I will change my anesthesia plan. So every patient is different with the age, weight, renal, hepatic function, comorbidity, drug response to all vary widely. So procedure today are more complex even with the minimal invasive technique requiring careful anesthetic titration. So there is a variability in the patient's response. Today the same patient for propofol response may not respond They response very deep anesthesia. Procedure complexity. Sometimes surgeon takes more time to complete the surgery. Demand for better outcome. Our surgeon demands nowadays daycare surgery. So that is why we need for the smart anesthesia now. TCI TIVA again going in the next few new generation is a smart anesthesia. So there are 6 smart anesthesia component. First, Dr.Shruti has very nicely explained the TCI TIVA algorithm. So precise drug delivery methods by TCI pump. Precision dosing. Dr. Subramanyam has told us that there are some specific drug dosings are given to every patient. So right dose for the right patient. Suppose today when I was given anesthesia for spine surgery, my dose was only 1 milligram per kilogram for propofol as my anesthetist told. But other patient may require 2 milligram. So individual drug delivery, tailor medication strategy, patient-centric monitoring, feedback-driven individualization. All these depth anesthesia monitors are working on that part. AI-driven feedback. This is a new words are coming that AI is taking in part of this TCI TIVA regimen and adaptive infusion, drug delivery guided by the patient state. Patient state where the depth anesthesia patient becomes light, patient becomes deep, then patient's hypotension occurs. According to that level, AI will decide by the smart TCI TIVA that how much drugs to be induced, what level should be kept in that state. So my objective of smart anesthesia is principle of TCI and TIVA, clinical applications, workflow integrations, AI enhancement, and future trend and ethics. So on these principles, I am going to tell my next slides in detail. Why there is a changing landscape of the anesthesia? Because there is a shift towards more personalized anesthesia delivery. Every day we cannot give the monotonous type of the anesthesia. Today we are giving propofol, remifentanil. Today we are giving to one patient. Every day when I am going for cholecystectomy, then all these basic principles are there. No, there is no need like that. I don't know about these patients, but if I feed everything in my pump, then they will take over. So need for enhanced precision and control over drug administration. Incorporation of the advanced technology in practice. We have a lot of AI gadgets, like we have chatbots, we have a ready reckoner TCI pumps and this ITIVA apps. There are so many other apps are available to grow. AI role in perioperative medicine. This is also one of the best idea to have this changing landscape. We'll come to, my topic will be divided in 2 parts, TCI and CLADS. CLADS means closed loop anesthesia. TCI, C has explained very nicely. TCI is a target control infusion, computer driven pumps that adjust the infusion rate and maintains the target plasma or effect site concentration. How it works? There are core components are user interface. So it looks like a simple infusion pump. The resident, those who are using simple infusion, they can switch over to and they can learn easily this our TCI pump, but they have to read something, they have to attend this type of the webinar, they have to attend the workshops, and from IOTA, our association, we are every year organizing so many workshops. So user interface, PKPD softwares are incorporated in this TCI pump, and there is an infusion pump control. Which are the models are available? Mars and Snyder. There are 4 generation models. First generation, second generation, third generation, and fourth generation is AI model. So Mars and Snyder are the first generation models. Kataria and Perfuser for the pediatric. These are the Minto, Bergman, Maitre, GAPS are for the opioids. They are different for the this remifentanil, then fentanyl, then other sufentanil, alfentanil. Domino, Eliveld. Eliveld is a new third generation pump available, that is, and Dick and Honeywood. Just these last two pumps are invented for the dexmedetomidine, and it is in the pipeline. They are having this, all softwares have in a general purpose model. What are the advantage of the TCI? Predictable anesthesia depth. Predictable. You do not worry about this awareness in anesthesia. This will create a havoc in past. I see lot of cases in private practice that our surgeon tells that my patient should show tongue, he should show eyes, and he should talk on table whether patient becomes aware or not. But that was the very shrewd anesthesia. I tell that days were gone. I started my practice in ether anesthesia and switch over to lastly sevoflurane, and then I started from Fortwin to remifentanil. So predictable anesthesia depth, fast recovery. Now today's everybody wants fast recovery, less PONV. There are two main complications in GAR: post-operative pain and patient having post-operative nausea, vomiting. If these two complications you take over in your practice, then you are mastering your anesthesia practice. And these two things you must avoid in your patients when there is a recovery in the post-operative period. Optimized drug use and cost efficiency. TCI uses PKPD models to maintain a target plasma or effect size. When it came in 1990 with the deprefuser, as Dr. Subramanyam told that propofol is our king or prince. After propofol, everything was possible. Propofol was the switch on switch of anesthesia. Like nowadays, I put a remimazolam, not remifentanil. Remimazolam is this switch on switch of anesthesia. It's a new generation drug. In 2026 or 27, remimazolam will take over the world. And after that, in 2030, you will believe me and remember that in 2030, China has invented ciprofol and it will take over the propofol, and every part of the world ciprofol will be in the use. It is better than even propofol. Dr. John Blair Glyer, Dr. Bain is from England, is the father of this TCI. Again, I am just highlighting another way of remembrance that how it works. 3-compartment pharmacological model, and bolus drug is given to central compartment. It distributes in the V1, C1, C2, C3. It eliminates in through the kidney. It goes in the effective side. Shripriya has nicely summarized everything with the graphs and everything. I do not go to in detail on this part of the slide. But this diagram shows the 3 compartments. The central compartment represents plasma lever when infusion and elimination occur. Peripheral compartment includes C2, muscle, highly perfused, fast equilibrium, and C3, fat, less perfused, and slow equilibrium. Drugs are distributed between compartments via rate constant, distributed and redistributed. Elimination occurs from the central compartment, and the effect side is linked to the C1 through the Ke0, reflecting clinical drug actions. This is the way the circuit is going on in the TCI pump. Now, these are the models are available in the market. Mars model. In bracket, I have written the which generation model is there. Just to know you people that how many types of the models are available for the specific drug. Mars was first invented in this after deprefuser pump, that is propofol. Snyder is 2nd generation model. Pedfuser and Kataria is for the pediatrics. This is used for the more than 3 kg. Minto for the remifentanil. Nowadays we are using for remifentanil in India. One of the company Themis came with the remifentanil, and every part of the, now you know the beauty part is that now out of 28 states, only 8 states are remaining to have a remifentanil. All other states are having a facility of remifentanil use. In our city also we are getting remifentanil. Bergman, fentanyl we are not using. Then another narcotics, this TCI pumps are, we are not using it. Alivel model is a 3rd generation model, and they have recently introduced in last 2 years for propofol and remifentanil. Domino for ketamine, Dick and Hennywood for the dexmedetomidine, Greenwald for midazolam, and general purpose model. You won't believe that when I started my practice TCI TIVA in 20, means before this corona, at that time all over India, Dr. Subramanyam will be agree that all over India there will be hardly 5 pump will be available. That is also with this Bangalore people. But today I should take it proud that there are more than 5,000 installation of the TCI pumps all over India by all the company. All pumps are available in all over India. So these are, which are these pumps? These are the TCI pumps: Arcomed, BD Elaris, HP Med Captain, B Brown. These are the few pumps are available, and the average price of these pumps starts from 1.5 lakh to 2.5 lakhs. Now my imagination is fourth generation TCI TIVA pump. This is my smart anesthesia. This is my smart TCI TIVA. AI driven, adaptive, closed loop and pharmacogenomics driven. Moving from simple PK models to truly smart autonomous anesthesia machine. You do not have to worry about any pharmacokinetic or pharmacodynamic of any drug. Just go and feed the data on this pump and pump will take over. Like we are running a cruise control over the car. Our car, when we put over the speed limit, then it will run automatically. Even if somebody comes in front of the car, then car automatically stops like that. Now how it looks, fourth generation, this is my dream. Integration of AI and big data predicts patient's response using real-time analytics, machine learning and pharmacokinetic. In this machine, more than billions of the data will be fed, like chatbots, our ChatGPT, which is fed by the so many articles, so many researches and like that. So this machine will be fed like that. So it's a great computer. This is artificial computer. So closed loop control. Infusion pump adjusts automatically based on the feedback. And for this, we are using bispectral index, entropy. These are all depth anesthesia monitor, null receptors monitor, that is a opioid receptor monitor, hemodynamics, multi-modal inputs, combined EEG, nociception monitor, hemodynamics and even variable biosensor. And according to that feedback, this pump will act all these. And I will come back to closed loop anesthesia. Adaptive and predictive, learns patient-specific PK/PD model. I told you, just feed the data and they will remember that for this patient, next time when this patient will be given anesthesia, then this same patient will be having these parameters. Towards fully autonomous anesthesia, anesthesiologist supervise while AI manages titration dynamically. It is my dream. This pump is not in the picture now, not is in the production, but remember in 2030 this type of the pump will come. Some TIVA TCI sets are available. These are the TIVA sets. There are two lines are there, drugs two. One is for fentanyl, one is for ramifentanil, one is for propofol. And the infusion line is different and directly it will be connected to the IV line. This type of the IV sets are also available. Now come to second part is closed loop anesthesia delivery system or automated total intravenous anesthesia. This is the ultimate of my topic. This is the smart anesthesia TCI TIVA. Closed loop system is the ideal means of automated. Here what inputs, whatever we are injecting in the body is a input and whatever the feedback, whatever the vital signs are coming from the body is an output through the monitors. So drugs are input is a drug. We are injecting drug like propofol opioids and according to that response, the monitor shows how it works. When these are all infusion pumps. So drugs are delivered in the body. Then the body reacts like what type of the monitoring is that, null monitor or entropy, what type of the depth anesthesia is there of patients, and accordingly vital signs will be adjusted and computer will decide that what drugs to be induced. Nowadays in my fourth generation pumps, the pump will decide that which type of the drugs, whether I want to put dexmedetomidine or I want to put a ketamine or I want to put a remifentanil more or I want to put a propofol more. So according to that, closed loop anesthesia will circle out everything. Patient himself it will maintain. See, you remember the ether anesthesia. In ether, patient will never die. Our surgical anesthesia says, colleagues are saying that ether will maintain itself the deep and light anesthesia. This for the PG resident to remember that part. This is the way diagram is shows. So clinical benefits of the closed loop system is dose fine tuning, adjust based on the surgical stimulus, whether such a surgeon is cutting some vital signs or a vital monitors or vital structures or suppose skin is cutting, then patient anesthesia is less, then it injects more. Safety limits, it stops the drug for the dangerous drops. I told the incidence of the cruise control car, if it goes more than 80, if you have a limit of 80, then if goes 80, then the alarm buzzers. The same way, if the BP or heart rate drops down or there is a hypoxia or there is a bronchospasm, everything will be told by the AI, and AI will speak over that, like our Alexa and Siri system. This is the way the pumps are coming here. They will speak out that, please listen that hypotension is there, so anesthetist will intervene and he will inject something. It gives the free hands, and anesthetist can focus on other tasks. Real-time monitoring, alerts for the abnormal patient reaction, and auto delivery. So what is the difference between manual anesthesia and automated anesthesia? There is a high workload. Every day I am doing 6 to 7 cases, but I am tired in the evening. But nowadays, after automated anesthesia, after my TCI pump, I do every day 10 cases till I am not tired. So this is the beauty of TCI TIVA, and even after TCI TIVA with AI, I don't know how much work efficiency I will get. This is the picture showing 3 different pictures that how closed loop anesthesia models are there. See, this is a computer, this is the infusion pump, and this is the monitor, depth anesthesia monitor. So this creates a circle. The one thing I want to tell you, our Dr. G.D. Puri from Chandigarh, who was a retired professor of this PGI Chandigarh, he has invented these CLADs, closed loop anesthesia system. And recently there was a World SIVA conference in Chandigarh. Unfortunately, I have not attended. I think Dr. Subramanyam has attended. But now CLADs is the ultimate things in the anesthesia. All in one TCI TIVA, CLADs and TCI both together like a Swiss jackknife. Both are working together. Both the pumps will act like together, and they will give the more accurate anesthesia program. Why combine TCI TIVA with AI? Because traditional TCI, whatever the Sripriya told, it was a traditional TCI. It was a predetermined infusion algorithm based on pharmacokinetics models, but does not adapt to change the patient's conditions. Suppose patient condition deteriorated, becomes slight, so TCI TIVA with AI, here artificial intelligence uses his intelligence to optimize the delivery. You do not have to worry that I will give some bolus dose of remifentanil, when to stop my remifentanil. Even remifentanil automatically stops. It will predict the time that surgeon has started the suturing the peritoneum, and it will reduce the dose. That is the way it will work. So advantages are balancing precision and efficiency in TCI TIVA with here, precise depth control. See, at the 60 of depth of anesthesia, means BIS reading, some patients are deep, and at 60 some patients are light. You do not have to decide. That will be decided by AI only. So there is a precise depth control, reduced drug doses. In this matter, I want to tell, when I was using propofol as a bolus dose, when total IV anesthesia, before invention of my TCI pump, at that time I used to give for short anesthesia 3 to 4 milligram per kilogram of body weight this propofol. Nowadays I have reduced to 1 to 1.5 milligrams. So there was a lot of wastage of the drug, predictable pharmacokinetics, and improved efficiency. So TCI TIVA will balance this solution. Routinely on AI having some advantages of anesthesia. See, I told you that in these 4th generation machines, lot of billions of the data was incorporated. So machine learning models predict patients' responses. Every part of the world, whatever the GA cases are done, they will be put in the some computer level data, and they will create a very good analysis. So continuous analysis of EEG, entropy and hemodynamics, early warning of instability or inadequate death. And these are the smart monitors we are using nowadays. These are all available in the market, but they are all costly one. Just now, if you go to this bispectral index monitor, entropy, process EEG machine, null monitor, all these around 3 lakhs rupees. And all these are now, every part of the world they are using these monitors. But everybody has no, in our private practice, we don't have that facility to use every theaters. So I use my own machines, and I carry with my machines in some theaters. So smart TIVA, by smart monitors, how they converge? By adaptive algorithm, BIS integration, entropy analysis, null integration, and patient response. So to complete this TIVA TCI by AI, these monitors are needed. we need a AI pump. So how algorithm adjusts the target based on real-time data, BIS integration enhances system monitoring and control, entropy analysis optimizes system performance and efficiency, null integration improves the system and accuracy. After the null monitor came, we are very fortunate to have a opioid monitoring and patient's response curve. The response of the curve will be also a learning part and adaptations. So overall advantage of smart TIVA is only major three part: faster, quick adjustment and emergence, safe, low risk of awareness or overdose. I hardly see awareness in my anesthesia after since last 10 years when I started my TIVA practice and after TCI. Precise, reduced variability and among patients. So ultimately it is patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly and a productivity friendly. I don't think that you should omit your gas anesthesia, but at least you start your TCI and TIVA in your practice. But there are some smart TCI TIVA challenges and limitations. Financial investment needed. For closed loop anesthesia, minimum 25 lakhs rupees of the investment is to be needed. Every depth anesthesia monitor is 3 lakhs rupees. Every smart pump is, this TCI TIVA pump is available at around 2 lakhs rupees, and other monitoring systems also are very costly. This even remifentanil is also 1800 rupees in the market, but we have to shift our change. Compliance delay the adoptions, clinical validation. So high cost and training and sometimes regulatory approval hurdles. See, I want to tell that I have to convince my senior people, my owner of the hospital to have a TCI pump for 3 years continuously. Then I got the TCI pump. This is the way we get as an anesthetist the problems. Sub-safety consideration in smart TCI TIVA. It is not like that when the TCI TIVA comes with the AI, smart anesthesia, then manually we should not be present. AI will not replace us. Manual override always to be available. The anesthesiologist must retain full control to intervene immediate. Our cognitive part will be less. They will take over. But our tactile part, whatever the hands, our hands are working to inject a syringe, to prepare a syringe, to inject in the vein, or whatever the way we have to act in an emergency, that we will decide. AI is an assistant, not a replacement. AI support decision making and precision, but does not replace clinical judgment or expertise. So continuous monitoring for artifacts. Nowadays, all these were alarms and some faulty reading. If you don't know how to drive a car, if you don't know how to operate a smartphone, if you don't know how to do any smart things, then you should learn first, then you do. Otherwise, just go and somebody is doing this job, some doctor, some anesthetist has previously started this type of the machines, then you should take. No, you buy this TCI pump, but you for that you attend one workshop, you read some journals, you see you should have some knowledge, this type of a webinar, then you practice it. Some future directions. You believe that this TCI TIVA AI, it will be a next level of the anesthesia in smart TIVA. This is a genome anesthesia. This is genetic pharmacology integration. Suppose as a Dr. Tushar Chokshi, 60 years male, is given a spinal anesthesia or something like any general anesthesia for laparoscopic surgery, then any anesthetist should not have. My genome data is with them, then they will feed over the smart pump, and that pump will take over everything. Which drugs to be introduced, what time will be there for the surgical stress, what time will be taken for the induction, what type of the PKPD, individual PKPD will be there for the individual drug for this. So genetic pharmacology, tailoring drug dosing based on individual genetic data. Wearable device integration, even this continuous glucose monitor, heart rate sensor, oxygen trackers, everybody will be integrated. My ambitions to see these pumps will have some minor monitors which will show some glucose monitoring, then pulse oximetry, everything. Autonomous anesthesia system. I will show at the end of the slide set how I have developed one of the AI enabled this anesthesia workstation of 2030. So developing AI system for precise anesthesia. It is not like that only pump will work for the smart anesthesia. Even we have anesthesia machines also for the AI driven. Now I will describe the two cases of how smart TCI TIVA with AI be there. One 65-year-old male, 80 kg, hypertensive, diabetic on treatment, scheduled for the laparoscopic cholecystectomy. He is a grade 1 patient. So in pre-operative phase, I have fed all the data in AI. Now AI selects the Snyder model and Minto for the remifentanil, Snyder for propofol. Induction dose already AI pump has selected, that is 4 microgram per ml, and remifentanil 3 nanogram per ml. And AI adjusts infusion with the Bayes and entropy feedback. So it will adjust like 3.8, 4.2 like that, 2.8, 4.2. Maintenance with surgical stress. When surgeon has started introducing trocar, so my null receptors has detected that null rises more than 30. So I have to put more opioid, means I do not have to put, but AI increase the opioid dose automatically, and it stables the SC for 45 to 50. In intraoperative adaptation, hypotension detected by AI. So MAP was 60 ml. AI pauses propofol and it alerts, it gives the alarm to the anesthesiologist by voice activating. Yet give vasopressors because infusion resumes at lower rate. In emergence at the post-operative, AI predicts the surgery end and it gradually tapers the infusion. So in recovery, smooth wake up, no agitation, minimal PONV, lower opioid use, and surgeon satisfied with the condition. This is the most safest anesthesia which by smart anesthesia I presume. This case highlights two things: precise drug titration with the predictive algorithm, real-time closed-loop adjustment based on monitoring, fewer complication, no smooth recovery, and still requiring the anesthesiologist oversight. That is why I told it will not replace anesthetists. Our presence should be there. Second case is for neurosurgery, craniotomy for tumor resection. 45-year-old female, 60 kg, no major comorbidities, scheduled for elective craniotomy for meningioma and ASA grade. Here you see in pre-operative phase what happens. AI system integrates in MRI based surgical time prediction with the patient data. MRI based AI system will integrate this data and they decide that how much surgery time will be there. And when there is a tumor resection, at that time I have to down the light anesthesia to the patients. So it chooses Aliwell model, third generation Minto model to maintain stable death and anesthesia. The plan includes avoiding deep anesthesia to the enabling SSCP, that is somatosensory evoke potential system, because we are using in neuro anesthesia. Induction target was low dose, means propofol 3.5, which we will not decide, that AI will decide, 3.5 microgram, and remifentanil 2 nanogram. AI adjusts titration, ensuring smooth loss of consciousness without pneumonia. Now in maintenance phase, when there is a during scalp fixation, null and hemodynamic stress was detected because they raised. AI increased the remifentanil to blunt this response, avoiding hypertension. During tumor resection, AI maintains lighter anesthesia for neuromonitoring accuracy. In intraoperative adaptations, patient develops bradycardia due to surgical manipulation. So AI reduces automatically remifentanil infusion, alerts the anesthesiologist, and surgeon pauses the manipulations. He will stop the surgery, and once the vitals stabilize, then surgery started. In emergence, AI gradually decrease the propofol and fentanyl 20 minutes before. It will decide itself that now I have to stop this infusion slowly, and there is a smooth emergence and neurological wake up. Recovery patient is extubated in OR, minimal hemodynamic fluctuations during surgery, no nausea, vomiting, transport to neuro ICU. So learning point is in neurosurgery, smart TCI TIVA with AI balances depth of anesthesia by unique need of neuromonitoring, ensuring hemodynamic stability and fast safe wake up. Now I will come to my future. This diagram I have prepared in 2018 to have my dream is how this my machine AI enabled anesthesia workstation will be there. I have created only one button. Our all these machines available in the anesthesia workstation available in the markets are having a tremendous this way, all these gadgets. So people are confused. So I have put only one button on that. I have put only one button, awake and asleep. When all the data are fed, then I want to put my patient on a anesthesia mode, then it goes in the asleep mode, and everything will be controlled by this anesthesia workstation and my AI pump. So I called it a switch on switch off anesthesia machine. And when I want my patient should awake, then I have to just switch off this. So this is the way. And I created in 2024 this blueprint, AI enabled anesthesia workstation. So there are some monitors, decision support, voice command, depth of anesthesia monitor, pain and fluid management automated. So I'm sitting here and I want to learn from, this is a robotic arm. Even intubation will be done by the robots, which is incorporated in this. These are the only one vaporizer for all three types of the inhalation agent. There are tanks inside one vaporizer. Even vaporizer will be decided by AI that which agents to be introduced in the body, right, for the gas anesthesia. And ultimately, in 2025 June, I have created this type of the anesthesia workstation, which is very famous now in all over world. This is the 2 robotic arm. This machine is a 2030 my imagination. But believe me, more than 1 crore rupees of trolleys available by Draeger in all over world. And we have fortunate in India that 3-4 trolleys are available. In Vadodara, we have 1 trolley is that. And this type of the trolley will be used in 2030. So this for August audience of my PG residents, I want to tell this is your future. So my key takeaway, smart anesthesia blends TCI, TIVA and AI for personalized care. TIVA delivers anesthesia solely via intravenous agents. TCI uses PKPD models to maintain target drug concentration. AI enables real-time adaptations using EEG, BIS, Mentropy and NOL. Closed loop system automate infusion with manual override safety. Benefits include precise depth, fast recovery and less PNV. AI is an assistant, not a replacement. See, there is $1 million questions people are asking, AI will replace everything. Not like that. If you use smartly, then it will never replace your own ability. Challenges include high cost, training needs and regulatory barriers. This will come out in the future when the drugs cost go low, infusion pump cost go low. Future direction are genetics. I will tell you, after 2 years, you will see that in every part of the India and outside world, genome anesthesia will be the hot topics for the discussion. Variables and autonomous systems. My core message of my lecture, this is just glimpses of my lecture. Precision with TCI TIVA. You start TCI TIVA, it's a new normal for the anesthesia, coming part of the anesthesia. Adaptability with AI, and those who are, see, there will be 2 types of the world. Those who knows AI and those who do not know AI. So you must know AI in your practice also, and judgment with the anesthesiologist. There are some light humor I have collected. The pump with the attitude. Resident tells that AI, sir, should I set the effect of target concentration manually? AI says, relax, I already know his age, weight, sex, genetics and Netflix history. So lesson is smart TCI TIVA adapts to multiple patient factor better than guesswork. Coffee versus propofol. Why did the AI TCI pump refuses to give too much propofol? Because it is said this is not a Starbucks, precision dosing only. Smart TIVA prevents oversedation by titrating exert amount. Genetics in the OR. Pump says, warning, this patient pharmacogenomics suggests lower metabolism. How do you know that? Unlike you, I read the genes. Smart anesthesia integrates pharmacogenomics for the personalized care. The honest monitor. BIS monitor to the anesthesiologist. Sir, I am at 60. Do not just stare at me. Sometimes what happens in 60 reading of BIS, we think that patient is light. But trust the term. Closed loop systems uses real-time feedback to keep anesthesia depth stable. That is why I told you the incidence that whether patient's BIS level is 60 or 40, this will be decided by the AI monitors only. Lazy anesthesiologist. Colleague says, why are you so calm in during this long surgery? Because my AI TCI pump worries more than I do. Lesson, AI reduces cognitive load, letting anesthesiologists focus on safety. So friends, The good anesthesiologist gives anesthesia. The great one with smart anesthesia care for the patient who receive it. Dr. Tushar Chokshi, myself, and I am a really am telling you, I am a generation of next 5 years, and I am no doubt I am an old man, 60 years male, but still I give anesthesia to my patient with my smart anesthesia. So thank you. Over to Dr. Mahankali.
Thank you, Tushar bhai. You always have a level. When we think that we are trying to catch up with you, you move 2 steps ahead. So your presentations and the topics, what you choose, is always like that. Now we thought we have reached you there, and you like jump 2 ahead. So that's wonderful to hear from you. There are a few questions.
This was just glimpses. This was just glimpses. This lecture was 1 hour job, but I have to complete within 30 minutes only. I omitted so many slides.
I thoroughly understand. So you have so much in your brain you want to share.
Yeah. I'll take again in our workshop.
Meenakshi sir, I will include you in the discussion as well. A few questions have come online, and we'll try and integrate both the questions so that the PGs can take home by the end of the lecture. Dr. Tushar, Dr.Sripriya, or sir, you can also answer. Who all should learn TCI TIVA? Is it only for the oldies like you, Dr. Tushar? I'm not saying oldies.
No.
So is it for a prior practitioner, the university, or the PGs? Who all you think we should learn about TCI? Dr. Sripriya, you can take the call also.
See, my views and my belief is that out of 60,000 anesthetists all over India, only 10% are in the corporates in medical colleges. 90% of the anesthesiologists are working in the private practice. Now, since my experience of 33 years, the people are giving monotonous anesthesia. Whenever patients, when dexmedetomidine was introduced in the market, and at that time, 15 years back, when I started giving all the lectures and everything to telling my surgeons and my anesthetist friend that you start using dexmedetomidine. Same way happened to propofol. Then they say that we are very much more happy with our old agents, and we are happy. Our surgeons are happy. We are safe in our anesthesia. They do not want to change. So I have to give them answer. Why are you changing your phones from this double phone to this smartphone? So like that, people should start. Why people are using ChatGPT, why people are using some of the latest instrument, why people are using smart car, why people are using the electric car. See, this is the way anesthesia is also changing. We want a safe anesthesia, we want a green anesthesia, we want a pollution-free anesthesia. So that is why my urge to all type of, every part of the world I am telling that you just stick to your old alma mater, but start something about TCI TIVA. Use TIVA, then switch over to TCI. This will be the future of the anesthesia, because see, new instruments are coming, new drugs are invented. Those will be in this race. They will be there. Otherwise, they will not be there. So this is the way my view is that everybody should start learning. At least PG should have that knowledge.
Moderator sir, with your permission, see, whenever you are asking about TCI, TIVA, or AA with Tushar Chokshi, he will be emotional like anything.
That is true,
sir. See, he has to become the president of this AOTTA, and he has to see everywhere the pumps are there. But I want to, just to pacify him, I tell, see, he is asking why you are changing your phone, you are changing your car, but you are not changing not the type of anesthesia. Why you are not changing the drug? I can tell you, he is monotonous anesthesia. See, for the past 34 years, I am married and I am living with a single wife only. I will not take chance in that. So the drugs are also like that. If you are comfortable with one drug, because ultimately the patient safety is important. This is just to pacify. I'm not against TIVA or TGA. See, anesthesiology is just like swimming. You can go for a butterfly or a breaststroke or a reverse stroke. You have to reach the shore safely with the patient. So as you say, he himself says, ether will never kill the patient. I have never seen, because ether automatically, once the patient is under full effect, the inhalation will be much less. So it is changing. See, it will change, but not at the speed of Tushar Chokshi. It will change at this snail space. It will change definitely. We
sir.
changed it. But you need not be so panicky. Why the world is not changing? That is not at all needed. See, it will be slowly changing. See, you have picked up. So don't think that everyone can match your intelligence. That is the reason.
I agree with sir. I agree with sir. But believe me, since last 10 years, whatever I am seeing in last 10 years, whatever I am seeing in last 5 years, TCI pumps are there more than 100 times than what I see in
That
2020.
is so. It was changing.
So
What I request you, it will change.
slowly it is changing now.
Just wait. Just wait. Change because overnight you cannot have any
No,
change.
Overnight it
Anesthesia,
will not change.
yeah, anesthesiology. See, we have to be comfortable because you yourself say by purchasing a pump, you should know how the pump operates. What are the difficulties in that? See, only anesthesiology is continuously we are learning. Once you finish one drug, another drug comes. Then again, Sripriya will come. This is pharmacokinetics. Then you will say this is pharmacogenomics. Then what I can do? Again, I will go to the same pentasosis because if you are changing, because I want to be comfortable. So slowly it will change. Over to you, sir.
Yeah.
Yes, sir. Dr. Sripriya, now one of them posed a question. We can extrapolate it a little bit. Now they asked, is there any way that intermediate also can be used for TCI? Now we just want to hear what are all the different drugs which you think are available for TCI. We just want to understand a little bit about that.
So for TCI, primarily what I've been using is propofol. Remifentanil is still, yes, it's not widely available, so we have not been using it. But propofol is what we are well versed with using. Etomidate assessed so far the pharmacokinetic models, whether they are in development or not, I'm not very sure. But the problem with etomidate is also that it causes cortisol suppression. How good is it that we are going to, if we are using it for infusion for a long time, what it does to the body is still, probably it's there in literature, but I've not thought about it so far. So that is what it is about the etomidate. But other drugs, if Dexmed, mostly we are using infusion pumps for that. I have not yet gone to use TCI pumps for dexmedetomidate. But the ITIVA app is giving us a method of using it with our infusion pumps also. Probably like coming to your previous question, what you were asking, I feel that both inhalation and intravenous anesthetic both methods will remain with us, because even if you are using TCI TIVA pump, the role of intubation and ventilation will continue to be with us. And just the way that we have been using balanced anesthesia, including all relaxant, opioid, hypnotics. So probably at some point of time, we may even feel like balancing intravenous and inhalation so that we are not actually giving more of one drug. So that also makes recovery better. So that is what I feel. Definitely, we cannot eliminate anesthesia machine from our practice because it is integrated with ventilators, and we have to take control of airway. TIVA may be a mode of providing hypnosis, relaxation, and those things. But just eliminating the machine is far from question. According, that's what is my opinion on that, sir.
You have summarized it really well. What I think Tushar also is telling us is we've already been using IV drugs for muscle relaxation, IV drugs for pain relief. So what we have only changed is instead of adding gas, there's a newer agents coming up which can maintain pure hypnosis of what it is there. But apart from that, we use IV drugs for maintaining blood pressure, to increase it, decrease it, all those things are there. There will probably combined, or which we call it as combined inhalation and volatile anesthesia, IV and volatile, it will be there. Very true. But what I have noticed is some of the newer pumps are coming with models for 14 drugs. So what I can also say is this concept of TCI, which first came in anesthesia, is now expanding to other domains as well. For example, chemotherapy. So you don't want to give a dose, you want to give a concentration which kills the cancer. So the same thing with antibiotic therapy, the same thing with glucose levels. What I personally feel is this target controlled infusions is only a start, wherein which we will have a much more understanding and a lot of patient dependent variables are being used. Tushar bhai, can you expand that? What are all the patient variables currently there, which makes it personalized, and what you see in the future?
See, there are glucose monitoring system, then oxygen monitoring. See,
No, no,
there are
for this anesthesia.
anesthesia, mainly there is a null monitoring, then entropy, then process EEG machines, then
Not about depth of anesthesia. For example, you talked about precision anesthesia, personalizing it. What are the currently available parameters which these models are using, and what is there in the offing in the near future?
means all type of the vital signs which are seeing on these monitors and everything.
Maybe I will just expand. What all these models are, they are personalizing providing anesthesia is using four fundamental parameters. That is the patient's age, patient's
Yeah,
height.
what you are talking
and
about the
gender.
parameters, okay.
But you also mentioned a few things about omics. It's very interesting term, omics. So you talked about genomics. So I don't know how many of you have already seen this article in Nature, perhaps one of the most knowledgeable, knowledge-oriented journals. It has published a gene which was discovered, which increases your sensitivity by 20 to 40% of your propofol. So we all have seen that the dose required in each individual is different, but it has identified. So identification of such genes, using that in the models will probably make it even more precise. And probably I also see omics. Omics involves not only genomics, the metabolomics, lipidomics, carbohydrates, all those omics. If once it incorporated, it will probably make our anesthesia even more precise. We can predict. I see a lot of role in prediction. How much dose is required, when they are going to wake up.
Not dose even, Shubhra, even drugs, which drugs to be given to this patient is also, because sometimes the scoline problem is there with some patients. So that gene will tell that this patient is very sensitive to scoline. This patient is very sensitive to the opioids. So genomic study is also very much important in future smart anesthesia. So you are absolutely right that genome study will be there, then it will change the scenario, because which drug is to be given. Sometimes propofol gives the reactions. Sometimes remifentanil is not suitable to the patient. So all these drugs will be decided by the genome study of the patient.
Dr. Sripriya, how are TCI pumps different from normal pumps? What is the difference in that, ma? Can you expand a little bit?
So a few things about TCI pump is, there are those algorithms that are incorporated in this. Like if we want to use propofol, we have the algorithms incorporated in it. And the data we have to enter is what is either depending on the model, either the effect site or the plasma concentration. And it shows us how the concentration is increasing. And we have a graphical representation also, a numerical representation also. And it should be able to deliver up to 1,200 ml per hour actually, primarily because during induction, the rate goes up very high depending on what is the model, what is the effect site concentration, what is the age, gender, height and weight, the parameters you have entered. So if we want to attain the level very fast, then it has to infuse at a higher rate. And then automatically it decreases, there's a pause for some time before the infusion starts. But when we go for the normal infusion pump, we have to adjust the rate.
So as I
So
understand,
because of the incorporated algorithms,
yes,
it
is like that, Sripriya, that we are driving a gear car and gearless car. So gear auto car is like they will adjust all the gears and everything. So basically difference is the computer softwares are inside these TCI pumps.
So true, so true. So from what I understand, so a normal infusion syringe pump driver, it just gives at a particular rate. Here we have sophisticated chips which are equivalent to computers, 8-bit chip and 16-chip computer, which helps you calculate the dose required, the levels achieved by using various models, right? Around models are there for propofol, for remifentanil, fentanyl, midazolam, dexmedetomidine. All these are there. One is the models are loaded onto the pump, and they are supposed to deliver the syringe driving at that rate. And there is one special chip to monitor that they are giving.
Yes.
Did I get it right?
Yes, yes.
Right.
Fantastic. So, sir, how much time we have, sir? Can take 5 more minutes?
You, sir, you can take because it is already we have exceeded the time. But the thing is, as it is interesting, we know only it is a lifetime chance for the delegates who are attending it on live. So first we will answer the questions, sir, whatever are the
Sir.
questions, then you can go for discussion.
Tushar bhai, somebody has asked, can TIVA be used for abdominal surgeries?
Why not? TIVA can be used from OT, outside OT to OT, even from neonates to geriatrics. Even it can be used from head to toe surgery, head to many surgical specialty. We can use TIVA.
Actually, Dr. Tushar, that question was asked by me only because you are specifically inserted a slide that TIVA produces relaxation. Now I want to know when propofol and remifentanil are commonly used.
No, sir. See, you do not understood the basic principles of TIVA. TIVA definition is the drugs given by intravenous route, right? Whether
Yeah.
it is a muscle relaxant, whether it is a opioid, whether it is an induction agent, whatever it may be. So TIVA completes with the even if see that is why I told you in this head. All my lectures, people are asking this question that TIVA does not does not include muscle relaxation. It is not like that. Muscle relaxations are there, but you should not give any inhalation agent including nitrous oxide. That is called TIVA.
No, that is what. Once a relaxant is introduced, it necessarily requires intubation. That is the reason why you are even having a robotic arm in your machine. So
Yeah.
once intubated, once intubated, then how will you maintain that intubation without IPPV?
No,
What
relaxant I will
what
give.
is your take on that?
I will take over to relaxation. That's what I am telling. I will not give any inhalation agent. I will not use my nitrous oxide. I will not use my anything.
Only oxygen, 100% oxygen ventilation.
Oxygen.
Is it
Oxygen ventilation. That's all. Air and my
actually
narcotics.
air? Then you can say you can add air because instead of
Yeah. Not 100%. Air also there.
better. So by doing everything,
I think main question
omitting
answer will be
nitrous oxide.
given by Subramanyam. How he will describe how he is giving TIVA in his practice TCI. Subra, can you describe one case from your side that how you not using nitrous oxide and all these other?
Once again, I want to add in this thing because 15 years ago in race anesthesia program, myself and Dr. Madhusudan Upadhyaya talked on that subject. That is nitrous oxide is obsolete. That is Madhusudan Upadhyaya's statement. Because he was talking for xenon. I said nitrous oxide will survive. So 15 years now we have discussed, but nitrous oxide is coming up. Now we have to think in that lines also, just to omit nitrous oxide. That is the only point you are saying. As far as abdominal surgery is concerned, just to omit nitrous oxide, and say under the disguise of saying we are reducing environmental pollution, is it right to purchase a machine costing 2.5 lakhs? To give that anesthesia. Is it right morally? I'm asking.
Yeah, definitely. Why? See, remifentanil is such a nice analgesic agent. Subra, you just got it.
I'm saying nitrous oxide. See, ultimately, by TIVA in abdominal surgery, you want to say TIVA, you will use everything. That is induction agent as an infusion and relaxation as an infusion and narcotics as an infusion. You will intubate also, but you will ventilate with oxygen and air. So what is ultimately happening? You are omitting nitrous oxide. That is the only one. Is it not? Then you
the major thing which we are omitting is volatile agents.
That's
the major thing which agent which we are using to keep the patient asleep is volatile agent. That is halothane or isoflurane or desflurane, etc. That is no longer required to maintain. We have been maintaining IV with this total intravenous anesthesia. The term is used when you're giving IV pain relief, IV muscle relaxation, and IV to maintain them asleep, which are the three fundamental triad of anesthesia. So all these three can be safely achieved. And the additional monitors are there to help you achieve that exactly you know what is happening to the brain. So now if I equate it, I know it can upset a few people. So, we've always been using Mariner's compass to tell us which direction to go. So people have used it safely for centuries to move from one place to another place. But now with the onset of Google Maps, what we have is the ability to know where the place is, how long it takes, which direction to go, which direction to take turn, when it is going to be busy. It's still there. But still occasionally it happens that the roads are blocked. So we may need to use my compass to say which direction we are using. So we can still use our traditional, whatever skills we have done. But what it gives us is the ability to give in every kind of case with less complications, with more safety features and individualizing. We are not giving no longer 1% for everyone. So here it gives us the ability to understand what is the level in the plasma. We are also not seeing just in plasma, we are just looking at the effect in the brain. It is relevant for volatile anesthesia also because we were not collecting data. But now it has been proven that people who give, for example, elderly, if their depth of anesthesia is deeper, they will have a very high incidence of POCD. People are expecting up in the elderly age group, nearly 40-45% of the patients will have POCD. The incidence of POCD will come down drastically when we start using TIVA. So if we stop using volatiles, it can drastically change this. Post-operative nausea and vomiting, it will change. I'm not saying this is a solution for all the issues, but it has got a role. There are people who might want to use it for nearly 80-90% of the cases. But I would certainly feel, because from the time I started my PG in 97, I have not seen any new volatile drugs coming in. So, but I have seen plenty of drugs coming in the newer drugs. All these drugs, which are synthetic drugs, will fall into the class of this newer soft drug, which are metabolized by esterases. So whether it is cypropofol or soft etomidate, somebody, Dr. Sripriya mentioned, we are worried about effects on the adrenal synthesis. Now this soft etomidate will not have any effects on the adrenal glands at all. So when you don't have effects, recovery is good. So probably still the safety features have to be studied. It has to be proven for us to use, and we will, all those techniques what we have learned will still be relevant. But what I see is the greater and greater role for TCI TIVA.
Methoxy etomidate you are talking about.
No, soft etomidate, yes.
Yeah.
And what also I noticed the difference is, earlier we used to get drugs invented in England or USA, but now we see this, for example, Remimazolam. It is coming from the East. It is coming from Japan. So cypropofol, the new propofol, it is coming from China. So I don't think no longer that West is the only thing there. So we are having drugs from different corners. The AI is being used to invent molecules quickly, and studies are being accelerated. What used to take 5 years to study now probably will study in 1 year and get the data out.
Sir, one question actually, what is BET stands for? Dr. Sripriya has mentioned it in the slide itself. I think anyway, I request to Madam to answer, sir, with your permission. The question was there, but she has mentioned it already in the slide.
Correct, sir, correct.
So BET stands for bolus, E for elimination, and T for transfer. So this regimen was designed so that we can induce anesthesia with intravenous agent and maintain with an infusion to obtain our target is to attain a stable effect site concentration. So this we can either do by just giving one dose, induction dose, or just by starting it with infusion alone. This requires a loading dose so that we can fill the central compartment, followed by an infusion, and the rate of infusion exponentially decreased, taking into consideration that the decline in the concentration in the central compartment is exponential because of the intercompartmental transfer decrement occurs exponentially, as well as the elimination is happening exponentially. So that is the BET regimen: bolus, elimination, and transfer.
So, sir, just I'll highlight a few things there, sir. Now, when we set a concentration, for example, 3 microgram per ml, so the machine will calculate how much bolus to give to achieve that plasma level. That is the B in that. Next is, it also knows, because you're given the parameters, what is the transfer rate, elimination rate happening from the liver and kidneys. And it also knows what is the V1 to V2 elimination transfer is happening. So the infusion is three things are there. One is compensating for the bolus, other one is for elimination, what is happening in the body, and the intercompartmental transfer is happening. So these three are called as bolus, elimination, and transfer. This regimen is used in all the algorithms which are published. So bolus, it calculates how much bolus to give. It understands how much of elimination is happening, and it also calculates how much of transfer between the compartments is happening. So BET will probably continue to stay with all the TCI models. So finally, to close this, can I ask Tushar sir? People have a feeling that giving TCI TIVA is costly. What do you think?
Nowadays, there are so many studies are coming that for safety part, the cost is not a major thing. And once the pump is purchased, then my propofol. Now you see, this propofol was when I started in 1997. Propofol was coming at 250 rupees. Nowadays, it is 50 rupees. Like that, remifentanil is costly. But inhalation agent, if you consider sevoflurane, that also in 1 hour, whatever the amount is giving, it is more than 1000 rupees. So principally, economically, if you see that maybe plus or minus range of the cost. So initially, you may have some costly affair of investing the instruments like TCI pump and depth anesthesia monitor. But ultimately, in long term, you are in benefit. So I don't think there is a cost to be included. See, in private practice, always cost to be considered main part when our charges are there for, suppose we are taking whatever the charges. But in corporates everywhere now, all these pumps and these monitors are used. So slowly it will pick up. No doubt, initially it is costly affair, but compared to inhalation agent, both are now same price.
What I also can share with Meenakshi sir is on an average in my hospital, for example, let's say you give 1 hour of anesthesia with sevoflurane, the cost comes to around 600 to 650 rupees. If I give desflurane anesthesia for 1 hour, the amount of usage which the machine uses, etc., comes up to around 900 rupees per hour. Propofol, if used as TCI with good analgesia, it costs around 750 rupees. So even if you're not using it appropriately, not appropriate analgized, etc., it will not cross 1000 rupees. So in terms of per hour cost, when we use it, it is almost cost neutral. It is same as other thing, at least in the corporate hospital, because they are charged per ml used. So because the cost of propofol has come down. So there is an initial investment because people have invested 20, 30 lakhs for a machine, vaporizer, etc. So it feels like you are adding a pump, the initial investment cost, but when we start using it, it's no longer a costly thing. It is almost cost neutral. But to make anesthesia safer, if we want to use depth of anesthesia monitoring, it's a BIS, which is probably relevant for volatile anesthesia also. If you want to be precise, you don't want to over anesthetize. If you add that, it costs around 1200 rupees for the entire case. So in that way, it is not a very costly affair, but we have to use it with judgment because it's a newer modality where we still feel don't as comfortable as volatile. So we start using depth of anesthesia monitoring a bit more frequently. The only additional cost, as I see, is because of we are adding depth of anesthesia monitoring. Do we need to monitor depth of anesthesia with volatiles? Maybe with sir's experience, he will manage any kind of case, any depth. But for most of the people, we still need to closely monitor. If monitoring is available, if it is affordable, there's nothing wrong with it.
Subramanyam, I'll give you one example. In my Vadodara, what I am seeing the changes since last 1 year, when Sugamadex was introduced, at that time people were very choosy for using Rocuronium and this Sugamadex, right? The cost went to very high. For 3-hour surgeries, where cost of these drugs went to 3000 rupees. So now surgeons were questioning. So at that time, people have started using Vecuronium with the Sugamadex. Now the cost came to 1/3 only. So people take the advantage of that drugs, that how the economics are benefited to us. So in 90% of anesthetists in my town now, they are using Sugamadex with Vecuronium combinations rather than the Rocuronium and Sugamadex. ultimately it gives a good way of the economics.
Meenakshi sir, I think we have taken more time.
Yeah.
I'll leave it for you
Thank
to.
you very much. Thank you very much, sir. Before I pass it on to our treasurer for the formal vote of thanks, see, today's webinar was interesting in one concept. See, all the faculty were enthusiastic. The way in which everyone was talking, see, really it is spellbound. The enthusiasm, emotion with which they teach, and due to the moderation is beyond comparison. I cannot explain anything in that. See that you should be a regular teacher, and I am worried that you are in a corporate hospital. See the way in which you teach. I am seeing another Panindranath in you, and this man Tushar Chokshi is always talking about 2050. 2050, you will see it, Tushar. Whether I am there or not, you will be seeing all the innovations which you want to have, and our trump card, Dr.Sripriya, always she is enthusiastic, and now. See, because of these three stalwarts, our Chota, Dr. Shruti, she wanted to talk only on one drug, propofol. But I said, you please talk about fentanyl and propofol. She wanted to talk about remifentanil, as you people may be thinking, why we have omitted remifentanil. Remifentanil already discussed in labor analgesia by Hyderabad team, Birthright by Rain Hospital. So we have not included that. And over to Dr. Emma, our treasurer, for the formal vote of thanks.
Sir, how many presents are there?
Tomorrow we will know, sir. Because the
Okay.
back-end team will be working. I will inform you.
Okay,
Tomorrow
okay.
we will inform you.
Very nice.
And I will put it up on the recordings also. Today
Okay.
it was wonderful. I think many people will be seeing the YouTube recordings also. That
Okay.
recording is so popular. And because of you people, Puthukkottai city branch has become so popular across the country.
Sir,
That is definite, sir. Tomorrow I will send you the number of people and the recording link also.
Thank you.
thank you from us, sir, and also from the IOTA team, which we want to take the safe practice of TCI and TIVA to every corner of the country. And thank you, sir.
Then I can request you, sir, you please, your team can take it over, just like a critical care medicine has taken over. So you take over 2 sessions, sir, within a span of 4 weeks gap, which is not
100%.
included. You please post your members to take part, so that
Yeah,
it
sure,
will
sure.
be propagated throughout the country.
Next time we can take a depth of anesthesia monitoring, sir.
Yeah, you
Yes, yes,
decide your topic, sir. We accept it just like that. And we are happy to have you as a moderator or a speaker in that. You
Anything.
be there. It is your responsibility. You fix one on PG and all we will post. So you fix 2 speakers, sir. This is the open request. Thank you then.
Thank you, sir. Thank
You have chosen that our president is the only we have chosen is the right way.
See, you have the team, na? Same way that critical care peri-operative association they have created, peri-operative care, where that Kapil Singhal from UP is the president and secretary is Dr. Sumedhu Sarkar. So they wanted to take over. I said, "Yeah, you take 2 sessions. That is your members. It is easy for me also. Now I'm doing only the editor job. I'm only a thread waiting for flowers to make a garland. That's all that I will do."
Thank you.
Emma. Dr. Emma.
Yes, sir. Good evening, everyone. I thank you all for your presence in the 31st episode on Total Intra Venous Anaesthesia in Puthukkottai Bhudhan webinar series. Our sincere gratitude to Dr. A.L.M. sir for guiding us and introducing us to all the star walls today in the future TCI and AA anesthesia workstation. Thank you, sir. Thank you, Dr. Shruti, President Mahatma Gandhi Medical College and Research Institute, Puducherry. I thank Dr. Sripriya, Additional Professor, AIMS, Mangalagiri, Andhra Pradesh. Thank you, ma'am. I thank Dr. Tushar Chokshi, Consultant, Vadodara, Gujarat. Thank you, sir. I thank our moderator, Dr. Subramanyam Mahankali, sir, Regional Director of Anesthesia Services, Krishna Institute of Medical Services, Bangalore. Sir, we are honored to have you today for guiding us, sir. Thank you, sir. Thank you, Clarinet, for continuous support. I thank all the participants, postgraduates, consultants, and for your continuous support and encouraging us throughout the series in increasing numbers. Thank you all. Good evening.
Thank you all. Thank you.
Over to Clarinet for the concluding remarks and closure of the session.
Sure, sir. Thank you so much to all the dignitaries present here. Clarence is really glad to have all these brilliant people together in this session today. and I hope you all had a seamless experience. So, with everyone's permission, I'm cutting the session in here for today and looking forward to host you again. Thank you so much, everyone. Good night.
Thank you all.
Good
Bye.
night.
Thank you, sir.
Thank you, sir. Thank you for our
Thank
sir.